A tracheotomy is one of the most commonly performed hospital procedures in the United States. Many tracheotomy patients are critically ill and have complex medical needs. Nurses need to understand tracheotomy tubes and, in addition to routine care, must establish basic competency in the management of trach emergencies. Proper placement of a tracheostomy tube allows airflow into the lungs. A dislodged trach tube may be recognized by a high-riding tube, but some dislodgements may not always be so obvious. Sometimes the tube is still within the stoma and appears in place from the outside, but is actually removed from the tracheal lumen. The trach tube may slip out of place and form an air pocket in the subcutaneous tissue in front of the tracheal lumen. This is also referred to as a false passage. Because there is no airflow into the lungs, this leads to respiratory distress. A decannulation is when the trach tube is completely absent from the stoma. This is good if the physician plans the decannulation because the patient no longer requires the trach, but bad when the tube is accidentally decannulated.
Can I ask you something? Sure. So what causes trach dislodgements and decannulations?
There are high-risk patients such as confused patients, obese patients with thick necks, patients with upper respiratory infections, and head and neck cancers. But the number one cause of trach emergencies is when doing routine procedures such as turning a patient, transporting patients, or changing neckties.
Oh my gosh, I'm getting a trach patient.
Really?
I don't even know what to do with trachs.
They're easy. I have a trach patient. You just have to remember it this way, the 3 S's. Sign, signs and symptoms, and steps. Come on, I'll show you. The first S is for trach sign. Always keep the trach sign at the head of the bed. Gather all supplies listed on the sign and keep at the bedside. Suction setup, ambu bag, spare kit of the same size, the original obturator if you have it, lubricant, Vaseline gauze, and CO2 detector. The second S is for signs and symptoms of dislodgement. Shortness of breath, airflow from the mouth, has a voice or is able to speak clearly, crepitus around the trach tube site, or high pressure lines if they are on a ventilator. The third S is for steps for safety. Always have 2 people at the bedside to turn the patient or change the neckties. Secure the tube. Have at least 1 to 2 fingers of space in between the patient's neck and the neckties. And know the steps to take in an emergency.
Kim, we turned Mr. Mannequin. Now he's short of breath.
He's saying, help me, I can't breathe. Oh, really? Oh my gosh, I need help. His trach came out.
Call a code blue first if the patient is in distress.
Susan, can you get me the 10 cc syringe? And then get the obturator ready. Okay. Are you doing okay, Mr. Mannequin? And you know, he's having a hard time breathing, so I'm just going to use the same trach. Can I get the lubricant? Okay, here we go. And then I need the CO2 detector, an ambu bag. It's gold. It's good.
If your one attempt is unsuccessful, do not reattempt. Cover the stoma with a gauze and use bag mask ventilation until the code team arrives. Nurses working at the bedside are the first line of defense. Preparation and early intervention are key during a trach emergency. and saving that patient's life.